I'm Janzan Rinkizon, and today I'll be addressing Amotivational Syndrome. So what is it? Amotivational Syndrome, also referred to as apathy syndrome, is a chronic psychiatric disorder that stems from long-term usage of cannabis or unregulated side effects of SSRIs. So intake of these then affect dopamine release systems and cause cognitive impairments. Specifically, the substance effect causes behavioral changes such as increased detachment from reality and loss of emotional reactivity, drives, and aims. It can span from general motivational loss for easy life routines such as personal care duties to finding it more difficult than normal to focus or finish a task. There are even some studies that link long-term cannabis use with impeded memory and attention skills. It is important to note, though, that this motivational loss should not be caused from emotional distress, intellectual impairment, or diminished levels of consciousness, as having motivational loss to these factors will classify them as symptoms for apathy altogether. In terms of parts of the brain affected, studies show that the frontotemporal lobar region is the most altered, with frontal lobe activity specifically being most affected. The drugs are said to mess with normal dopamine and serotonin release schedules and cognitive functions. So how do we treat amotivational syndrome? It depends on which substance you use. It is recommended that for cannabis users, addressing the dependency issue would be most helpful. So usually they would ask clients to seek treatments addressing drug addictions and also recommend greatly reducing the usage of it so the drug does not get opportunities to affect the frontal lobe activity. As for patients affected by the SSRI-induced version, it is recommended that multiple follow-up appointments are made with the psychiatrist who prescribe SSRIs so there is an opportunity to review side effects with the clients. Barnab and Colwees gave a 3-step plan in addressing SSRI side effects by first take the titration approach, and if that doesn't work, move on to augmentation, and finally trying to switch to a different class of antidepressants altogether. For current research, there are continued arguments regarding the validity of the reported severity observed from cannabis users, as some studies find inconsistencies in the test groups of partakers of the drug that are affected with the syndrome and people who took the drug and did not show any amotivational symptoms. This encourages research directions to look at probable factors or comorbidities that affect which users are affected and which are not. So suggestions span from mixing alcohol with the usage to personality traits making them more susceptible to it. So for SSRIs, there is increasing research interest in informing the field of how overlooked the side effects are, and it's evident in prescriptions for SSRIs since they're very high nowadays. They are also looking at potential ways to reduce side effects for users of them and found medication changes could potentially cause more harm by having clients deal with withdrawal symptoms. This suggests the need to adopt some drug addiction therapy as well when treating people affected by SSRI-induced amotivational syndrome. That's the end of my presentation. Thank you for listening.